All right. All right. So, good morning, good afternoon, and good evening to everyone. I am Dr. Akri Asenbang. I am the co-founder and board president of the Pan-African Organization for Health Education and Research. I am very happy to be here with you this morning. We have just a wonderful, wonderful program planned for you today. As you know, October is Breast Cancer Awareness Month, and as an organization, we have dedicated several webinars this month, for you, the audience, for you, the general population, and, even for experts. We do have a wonderful panel across the month. We're starting off with looking at breast cancer from a medical perspective, and then we'll move on towards the middle of the month and focus on patient advocacy with Dr. Omondi. And at the end of the month, we'll focus on the surgical component, surgical management of breast cancer with Dr. Mutebi. And so our format is, as always, some of you send in questions. So this is just, discussion one-on-one between our scholars and our experts. And for this morning or this afternoon, this evening, wherever you are, our scholar is Mwenya Musonda, and our expert is Dr. Catherine Mwaba, who's been with us before. And so we are, again, on behalf of POHER, just super grateful for her time that she is dedicating to this conversation. So some of you know Mwenya. Mwenya is one of our fantabulous POHER scholars. She is a sixth-year medical student at the University of Zambia, School of Medicine in Lusaka, Zambia. And not only that, Mwenya is actually one out of the over 20,000 applicants who was accepted as a Millennium Fellow with the United Nations. And Mwenya can correct me if I'm not speaking correctly, but we're just excited. I mean, I just keep focusing on that, but just imagine thousands of people apply for something and you get selected. So we are just, we're beyond proud, and we look forward to hearing about what her program is in a future session. She can tell us, what she plans to do. So we look forward to that. All right, so let's get into the program. I will hand things over to Mwenya, who will, introduce our speaker, and then we'll get right into the questions. In terms of format, if you're watching this in the webinar, please feel free to type your questions in the chat box. Feel free to use the Q&A. If you're watching this on Facebook Live, feel free to drop your questions on Facebook Live as well, and we'll try to get to those questions. So once again, good morning, good afternoon, good evening, and welcome to this conversation on breast cancer from a medical perspective, a medical management perspective. And Mwenya, over to you.
Thank you so much, Dr. Akri, and thank you, POHER, for this opportunity, for this, for granting us this platform to discuss breast cancer. As we know, this month is Breast Cancer Awareness Month. And then for today, we are honored to be joined by a specialist, Dr. Mwaba, who is a clinical and radiation oncologist. We are more than delighted to have this discussion with her, and I hope that all of us in this webinar will be able to learn quite a number of things from this, and we'll follow up perhaps next week to go for breast cancer screening. So I would love to introduce you to Dr. Mwaba. Dr. Mwaba.
Hi, good afternoon, good morning, good evening. So as Mwenya said, I'm a radiation clinical oncologist, and I'm really delighted to be part of this effort by POHER to not only grow our next gen specialists in different fields in medicine, but also just to share some of my experience, knowledge when it comes to breast cancer. I do refer to myself, apart from a specialist, that I'm a cancer advocate, and I do love to do that part of the work. So thank you so much for having me.
Thank you. And then, we're so inspired by the work that she's doing. So just for us to be acquainted with what exactly she does or what exactly it is that we are going to base our discussion around this afternoon. Dr. Mwaba, could you please tell us who an oncologist is, or who a clinical and radiation oncologist is?
All right. Okay, I'll try and do it in at least a minute or so, because it's really important for people to begin to appreciate the role of, I'll start from talking about nuclear science and technology. And in my interaction with medical students, I do encourage them to consider specializing in fields that are related to nuclear science and technology, because it's an area that is not very familiar. I trained in South Africa with 3 other colleagues at the time we started, and came to learn about the use of high energy X-rays to treat cancer, basically. And the other component is use of drugs, systemic treatments for cancer. That's the medical oncology component. So when you combine the medical oncology component and the radiation oncology component, you are referred to as a clinical oncologist. But within the concept or the area of nuclear science and technology, if I may be given just an endowed or indulged to speak about nuclear science and technology, I ask people, have you ever had an X-ray done? And they're like, yeah. So in essence, you are benefiting from the applications of nuclear science and technology for diagnosis. So if you've heard of fields like nuclear medicine, which plays a great role in diagnosis. We ask you about PET CTs. That's that area where these technologies and the science behind radioactivity, behind X-rays is used for good. So I thought I should just bring that component out, because I find that we don't talk a lot about that, and hopefully we can get people who are going to take the route of becoming scientists, because we do need those, your medical physicists and such specialties that are not very common, not only in Zambia, I must say, but generally in Africa as a whole. Yeah, so simply put, an oncologist is a doctor who studies how cancer develops, what you do to treat it, and how you work in a multidisciplinary team to obviously make a diagnosis, stage the cancer, treat it, then you have your follow-up and rehabilitation of the patients that you treat.
And it looks like Mwenya may have frozen there. Mwenya, are you still there? If not, I could take over and ask a few questions that we have, and then once her system comes back on, we can carry on from there. So let's see here. All right, yeah, I think it's okay. All right, so whenever Mwenya comes back on, I'll let her take over. But I think, thank you for that explanation. I think it's really important. So when a patient sees a doctor, they know who the doctor is and, and why they're seeing that doctor. But so let's get into this discussion on, on breast cancer. So can you just explain to us and to the audience what exactly, what is breast cancer?
Thank you for that question, Akwi. And I'll try not to use technical terms, because doctors are always accused of being too technical when they explain things. So basically, I start by saying we are made up of cells, which are then organized into tissues, organized into organs. So in human anatomy, at least we know there's the ear, there's the tongue, there's the breast. So the breast has cells, and obviously within the experience of growing from a little girl, to your maturity, all the way to adulthood. You see the breast bud, you see the breast grow, and eventually this organ, which is made up of these cells, can, if the cells do not divide properly, there's loss of control of the cells dividing. They begin to multiply and they grow into a lump that we talk about when we talk about symptoms. So breast cancer basically is the abnormal growth of cells. Abnormal is the emphasis, because you can get growth in a breast that is not abnormal. So that's as close as I can define what breast cancer is. So cancer, sometimes you hear the term malignancy, so it's abnormal. So if there's a growth, the only way you know it's abnormal is when your pathologist has looked at the type of cells and they really then classify to say, okay, this is invasive, this is not your malignant process, your fibroadenomas type of thing, and we term that breast cancer.
I'm glad you pointed out and used the word malignant and the word cancer, and I'm glad you also put that emphasis on the abnormal cells in terms of diagnosis by the pathologist. So then the next question is, what are the risk factors for breast cancer? And at some point we'll come to the gender question, because that was an important point. But when you started speaking, that question also came up. What are the risk factors for breast cancer? Who can get it? Why?
Okay, so generally when we begin to talk about risk factors, and first of all, people will ask you what led to this condition. So there are certain things that happen that sort of give you that environment that allows for something to go wrong. So with breast cancer, you don't have this one single reason why you develop breast cancer. Hence, we talk about the risk factors. So what are these conditions that would be fulfilled for somebody to develop breast cancer? And I like to really, first of all, divide them into two groups. You have those risk factors that you can modify. You can do something about, you can change. And those are the famous one we listen to about, your obesity, parity, like how many children do you end up having from 0 to 10. So you do have a little bit of control over the number of children you may have because of all the planning that goes into having a family. You may take things like oral contraceptives, you may take things like hormone replacements. These are things that are modifiable, right? You can actually do something about that and change them. So when we talk about risk and we're looking at modifiable factors, we talk about obesity, we talk about sedentary lifestyle. So you have to have an active lifestyle, you have to exercise. And we do talk about the issue of exogenous, that is outside, taking in hormones, because remember that females do have their own hormones. Our makeup is controlled by, like I started, little girl, puberty. So you're having these reproductive hormones that unfortunately you wouldn't be able to do anything about. So when I go to talk about the non-modifiable risk factors, the first thing we talk about is gender. Breast cancer is more common in the female than the male, but the male also has a breast, rudimentary, so you do get 0.3% of all cases will be in the male. But because we are female with more breast tissue, we are more at risk because we are female. Then we talk about issues of genetics. Now, genetics is a little bit complex because some people think that that's the larger reason why people develop breast cancer, but actually it's not. It's about 10, maybe 8 to 10% of all breast cancers will have a hereditary component to it. So my mother, my grandmother, my first cousin had breast cancer. And what has been found in the literature really, or in research, is that there are these BRCA genes that they call BRCA1, BRCA2. So you may have that in you. But I must hasten to say that currently, within the context of Africans, African Americans, and non-Caucasians, there is a debate as to whether these BRCA genes are really the drivers. Is there a racial component? So there's quite a lot of excitement in work and research to begin to understand breast cancer, and hopefully we can tackle the differences. You know, we get breast cancer very early on in life, like 10 years earlier than in the Caucasians, but you find that the Caucasians have more breast cancer than the Africans or African Americans. But when the Africans or African Americans have breast cancer, it's more aggressive, that type of thing on the biology. So there are other factors like exposure to radiation, which seems counterintuitive. If, for instance, someone had a lymphoma, it's quite common. Hodgkin's lymphoma occurs in the young, adolescent, young adults, and part of treatment for Hodgkin's lymphoma actually includes radiation to the chest. So if you had previous radiation to the chest, you might then be predisposed to developing breast cancer. So we talk about the reproductive issues. So when you're very young, you start having your menses. You stop having your menses at a much later age. It means you have quite a long, protracted period of exposure to your estrogens, right? So we say unopposed estrogen exposure. So your early menarche, and I tend to I'll explain in simple terms, but I'll use the medical terms because we need our audience to begin to be comfortable with these terms that we use. The other one would be on issues of breastfeeding, which can be a little bit controversial. So women who have more children, who breastfeed longer, are protected in a sense against breast cancer compared to those that don't have kids, or they have a few, your small number. We are all women. We are striving to advance ourselves. So we tend to have our children much later in life, like age at first child, you'll be 30 instead of your 20s in our grandmother's time. So those things sort of play a role. So when you begin to look at the reasons or the risk factors, they're quite complex, but simplified, think of those you can change, then think of those you can't change. You can't change the fact that you're female. You can't change the fact that you are aging. As much as, yes, we say Africans develop breast cancer a decade earlier than in the Caucasians, aging is actually one of those known factors. So obviously, if I've left one or two out, we can just have a discussion so that we can at least give time to talk about other things as well.
Oh, thank you. Mwenya is back on, so I'll definitely be handing things over to her. But you already took the next question that crept in my mind when you made the comment. You were using girls, as an example leading to breast cancer. But you answered the question that I had about men. If men can get breast cancer, and you pointed out rightfully so. If you have breasts, you can get breast cancer. And so even though it's a small percentage in men, they could still get breast cancer. So, thank you. And I like how you broadly said modifiable versus non-modifiable. Modifiable, you can change. Non-modifiable, you cannot change. That's really a very good, definition and clarification for risk factors. So Mwenya, Mwenya looks like she's settled back in. So Mwenya, I will hand things over to you again. And I'll be in the background and I'll step right in if you have any issues. All right, over to you, Mwenya.
Thank you so much. My apologies for that interruption. So now we know what breast cancer is. We'll move on to how really this breast cancer presents. What are the symptoms? Dr. Mwaba, please go before us.
Okay, yeah, that's an important thing to begin to understand the early signs and symptoms of breast cancer. Obviously, in the very early stages, you might not see anything. And in your post-menopausal women, for instance, you've heard of mammography. So you do your x-ray of the breast, and in some countries there is screening, so that mammography can pick up abnormalities that anyone can't feel, can't see. So you could have your very early signs, which are only picked up using your x-rays of the breast. But generally, we talk about things like the change in the size of a breast, the lump in the breast, the discharge, which is abnormal through the nipple. It can be bloody. You can have pain in the breast or an underarm swelling without even anything that you feel in the breast. So those are some of the early signs of breast cancer. As the disease progresses, obviously this lump grows, it becomes a wound, it breaks out of the skin, there's bleeding, it can be infected. So you get a lot of infections that can be local, or these infections can actually also be quite widespread in the body. At that point, you know that the cancer itself is progressing. So as the disease is progressing, if there's nothing done, then you begin to pick up all these other symptoms and signs that will show that the cancer might be in the brain: convulsions, confusion, headaches, vomiting. It might be in the liver. You get your, yellowing of the eyes, your easy satiety. We call it like feeling full very early because the liver is swelling and there's disease in it. Bone pain is quite common in very advanced stages of the disease. So one has to look at these symptoms and signs from the very early one I said, where you can't see anything, and that's where screening comes in. You pick up these changes in the breast that you can only see on your x-ray of the breast, which is called mammography, all the way to the point where someone has developed cancer now that has gone into other organs, and commonly it might be the lungs. So your failure to breathe, you are tiring very easily because there's fluid collecting, because the lung tissue itself is now being replaced by the cancer. So that's really what I can say about the early signs, or just generally the signs and symptoms. So think of them from early all the way to advanced. And we don't want people to come with, back pain or inability to walk, because that means we missed the boat. We could have caught this early on and tried to hopefully cure, in inverted commas, I always say, because cancer is such a complex disease to treat. Yeah.
Oh, your mic is mute, Mwenya.
Yes, thank you so much. I was saying, I think your explanation, Dr. Mwaba, has tackled the other question I had, which addresses the complications of breast cancer, of which you have alluded to, saying we have difficulties in breathing, chest complications, and whatnot. I would like us to move on to screening. How then will somebody be enlightened about whether or not they have breast cancer? How often should they screen? And who exactly is supposed to go for this screening? Thank you so much.
No, thank you, Mwenya, for that important question. And I'll take a little bit of time here because I have noted a bit of confusion when we talk about screening. So by definition, screening is looking for something in a healthy population, right? So there'll be methods you're going to use to try to find something in this healthy population. So let's say you have a target, and the ages differ for different countries when they start screening. By screening women who do not have symptoms, you are hoping to catch the disease at stage 0, hopefully. So within the context of the global or international guidelines, you'll find that, and screening is done with mammography. So you have to have technicians, you have to have radiologists, you have to have a whole set of specialists in that area. So let's say country A has a policy on breast early detection through screening. So they go out, they'll remind you, you are 50, you've never had a mammogram, please come through. So you cast your net very wide and you call your population, your target population, and you x-ray them basically, but you take their histories, you examine them as well. So another method is a clinical breast exam. But now you come to the issue of where I'm going to. In Africa, really, we do not have countries that do population-based screening. Part of it is because we don't have the resources to. We don't have the specialists to. It's a pretty expensive venture. So what do low resource settings then do to ensure that we detect breast cancer early? We then encourage people to understand the early signs and symptoms. We have what we call doing your clinical breast exam coupled with an ultrasound of the breast as the very basic steps to screening. And now it's going to sound a little bit confusing, but I will use the term screening because I won't use it in the term of population-based. We have what we call opportunistic. So we are sharing right now, right? So women that are going to fall into the area we say can go and have their breasts examined will turn up at a facility and they'll be attended to. They'll have a clinician or a nurse who is going to examine their breast. If we find any lump in such a person, we're going to send them to have an ultrasound done. If they are of an age where a mammogram can be done, mammography will be done, and the next steps follow, because you have 3 steps that you do. You do your clinical breast exam, you do mammography, in fact, you do your ultrasound, and if there's a lump, you have to take a tissue out of that. So you do your biopsy, or you take a piece of that lump, whatever it is, so that you can send it to the lab again to come back to what we discussed earlier, to know whether this is a process that is not cancerous or whether this is a cancerous process. So just to clarify, and if there are any questions, we can discuss this further. The understanding of screening is that you go out to a healthy population and you have mass sort of screening so that you pick up. But remember, you need to have facilities or the ability to treat cancer. So within the context of low-resourced environments, it is not really a feasible approach, but it's important to be aware of it. So that people know. But within the ages, I said 50 and above, some countries say from 40 and above, depending on your we call it your disease profile. By disease profile, it means that countries know their epidemiology or their statistics, and they do then create these programs to tackle whatever condition they are tackling that you can screen for within that context. But for breast cancer, it's a little bit difficult for our setting to do your mass screenings. And our setting, I'm referring to low-resourced environments. So I hope that is clear, but I'm here to clarify for anyone who has not understood anything. Yeah.
No, that was actually a pretty good explanation, but I think the one question I would ask, just sort of from what you've mentioned with screening, if you could pick an age, you're based in Zambia. So at what age in Zambia, and maybe you mentioned this, but maybe, just to stress it, at what age in Zambia would someone come and start getting their screening? And does them having a family history, impact that timing?
That's a very important question, Akwi. So within the context of our setting, we do encourage to learn your breast from 25 and above, because we've had 26-year-olds with breast cancer. But those who are under the age of 40 are only having your clinical breast exam done and an ultrasound. Those who are over 40 are the ones within the context of Zambia that then we go on to do mammography. But they then come, well, it's been sort of difficult to say, is it yearly? But we've been encouraging yearly screening in a sense. So if you are under 40, obviously you learn how to examine your breasts yourself, but at least once a year you should have a clinician check you, and that's what we're calling your clinical breast exam. Now, your family history component, again, is a difficult part of approach to diagnosis within the context of low-resourced settings. High-resource settings would be, okay, let's check your genetic profile. Let's see what we can do to address, because if you're going to have a very high risk of breast cancer because your mother had breast cancer, your sister had breast cancer, you have history of ovarian cancer in your family, and then you, the individual, tend to have your genes that we talked about, then they would really go on to put you on a program. So your geneticist comes in, and we talk about mentoring. So far, we don't have any geneticists in Zambia. I'm not sure within the context of other African countries how they're faring on that, because it's also a very difficult type of place to be. I always go back and say, remember the Angelina Jolie effect? Very famous actress. If you love movies like me, yeah, she had a very strong predisposition to breast cancer. She went on and had her breasts removed prophylactically. And I think they may have removed her ovaries or something like that as well, just to reduce her risk of getting breast cancer. But those are the sort of glaring differences. In one, you have your facilities where, yes, we can check whether, because if you may have a family history and not necessarily be at a high risk, so you need a geneticist to see you, you need a gene profile to be done so that we establish whether you really are truly at very high risk. But I suppose then, Akwi, to sort of complete and answer the question, your pattern for screening then becomes different. So you need to be a little bit more careful, more aware, and always go whenever you pick up something that you're not comfortable with to see the doctor, so that we hopefully not, but we diagnose the cancer in its very early stages if it does develop.
Oh, thank you so much. Before I hand things over back to Mwenya, I'm just going to pick one question from the chat, which I think is a really interesting question. Does your breast size matter in terms of developing breast cancer? In other words, whether you're a small breast or you have large breasts, for people who wear bras, are you a size A versus a B cup or C or a D cup, etc.? Does it make a difference if you have small or large breasts?
Large breasts.
Yeah, does that matter?
A very interesting question. Actually, not. It doesn't. What might be difficult for large-breasted women is your clinical breast exam. It's easier, to feel something in a smaller, when we're doing our clinical examination, you're palpating, it's actually easier to palpate a small breast. But in terms of, does it matter the size? No, not really, it doesn't.
Over
to you, Mwenya.
Thank you so much.
Yeah, and we just
options. My apologies. So
no problem.
Yes. So in the event that one is diagnosed with breast cancer, what treatment modalities are there for them? And I would love you to comment if breast cancer is curable in the treatment modality.
Yeah, I know that there's always this, the longer I've now practiced as an oncologist, I always tell my clients that I'm very careful to use the term cure, and I equate it to, if you have malaria, right? You do your RDT or you do your malaria parasite test, and we see you've got parasitemia, and we give you, is it Coartem that is being used nowadays? We can clear that out of your system, and literally we can say we've cured you because we've literally taken away everything. But maybe malaria was not even the best example, because if you live in an endemic area, you might get it again, right? But the context of cure in cancer is difficult one. Why? Because when you treat breast cancer, it does have a tendency to come back regardless of the size at initial diagnosis. So the time it takes for cancer to come back is what is very varied. For certain people, it's a short time. For certain people, it can be decades and decades. And for those, I guess, that then demise of something else and they're cancer free, I guess you then could say you had cured them of cancer. So I hope that sort of long-winded explanation about cure settles the question on curability. But when it comes to modalities of treatment, and Mwenya has used modalities, basically what methods are there or how do you treat the breast cancer? One, it's a very complicated disease. Therefore, you can only treat it using your different methods. Surgery is the cornerstone. And why is surgery the cornerstone? Because you get your diagnosis through biopsies, but you have to remove the visible disease or the diseased breast where the cancer was to achieve good results at the end. And I'm sure Miriam is going to tackle the issue of the surgical management. Then at the same time, yeah, exactly. Now we talk about breast cancer as being a systemic disease. So regardless of how small the mass is, you may need some systemic treatments. That's the medical management part of it. Chemotherapy, hormonotherapy, targeted therapies, immune therapies. These are now treatments that are addressing not only the local disease, but the fact that some abnormal cell may have escaped the breast, gone into the bloodstream, and gone and sat wherever in the body, right? So your systemic treatment becomes very important. So surgery, chemotherapy, and I've gone through the different types of systemic treatments. What about radiotherapy? Why is radiotherapy important? For certain stages of breast cancer, even if you've done excellent systemic treatment and you've done excellent surgery, you cannot have good results if you don't give radiotherapy. So I'll give an example of early stage breast cancer where and Miriam is going to talk about this, where you do your breast conserving treatment, you remove the lump, you remove some lymph nodes in the armpit. 100%, if you're going to get good results, you need to give radiation to the local breast, we call the chest wall, either the whole breast and the areas, we call those regional lymphatics, like where does the breast drain to? So surgery cannot remove all those different stations of lymph nodes for the breast, and radiotherapy then will help to sterilize that type of area. So yeah, so and again, palliative care is one of the components, because you have to manage the pain, you have to manage the other complications. So modalities, surgery, chemotherapy, radiotherapy, and your targeted treatments will be like your core, plus your methods to deal with issues of very advanced disease to improve quality of life of your patients. Yeah.
Okay. Thank you so much. Thank you so much. We've learned about a lot of treatment modalities, but then I would love to find out, are there instances where a patient is denied treatment? The facility is there, the equipment is there, but then is there an instance where a particular patient is denied treatment?
Okay, so when we talk about access to treatment, we are exactly like you've just summarized. Facilities there, everything is there, but there's a patient on one hand, right, who may or may not have other conditions within the context of, yes, they've got breast cancer, but they may have what? Infective conditions, they may have diabetes, some other non-communicable disease. And depending on the stage at which your patient presents to you, and I hope this is not misunderstood, so I'll try to clarify it a little bit. You may get a patient, let's say, with very advanced stage disease, whose prognosis is, from your assessment, is not very good. And you as a specialist is obliged to say, well, this treatment will be more harmful than the benefit. So in that instance, you can deny treatment. The other component, I guess, is to do with access to newer types of treatments. And that's a scenario where patients are enrolled into clinical trials. It's not a very familiar feature for ourselves because, one, we don't have access to your newer drugs. At least from my practice, I always say we are 3 decades behind what is current in terms of development of systemic treatments, right? So in other countries where they are resourced, they do a lot of research, a patient who has had several prior treatments can be enrolled into a clinical trial. Now, when you think, do they enroll everybody? No, they don't. You have to meet certain criteria. So in that context, then you can be denied being included into a trial because you did not meet your, the criteria for them to include you in that clinical trial. But at the same time, not from the service delivery perspective, but from the patient's perspective, right? I don't know whether we can term that being denied treatment, but a patient can refuse treatment. You've explained everything, but for whatever reasons, they may refuse treatment. And you as a specialist is obliged, when your client comes back, to help them at the point that they do. But at treatment refusal, you are obliged to really do a lot of counseling because it's a devastating diagnosis for many. Right? And it's scary. My life is shortened. Am I going to die? So sometimes a patient may refuse treatment because they don't actually understand the condition they have. So we have to do a lot of counseling. And again, when we talk about modalities, your psychotherapists or your clinical psychologists are a very important tool or specialty to work with for our patients.
All right. Thank you so much. And somewhat in your explanation, you've addressed my next concern, which is about why exactly do patients deny treatment? Treatment is there, but then why would they opt not to have the treatment given to them? And then, is it advisable to do so?
Well, what is it we are taught in med school? We talk about informed consent. That informed consent process means the doctor has explained the condition I have and I have understood the outcomes if I go on treatment or if I don't go on treatment. One of our weaknesses within the context of our practice is actually that component for me and from what I've observed and working, in a cancer unit is that sometimes we have a huge patient load, so we tend to be very quick and fast and we don't accord our clients that time. So your patient actually will refuse treatment, not because they want to refuse treatment, but because they have not understood the meaning of this diagnosis that you've made and the complications of the disease. But remember again that when you are giving treatment, you also have to explain these treatments are not harmless. These treatments have side effects. So it has to be a balance between your benefit and risk and understanding that, look, if untreated, this is what is going to happen. Treated, yes, I'll lose my hair. There'll be nausea, vomiting. I may have severe infections because my white cell count fell very low. But at the end of it, when you've gone through this, you are going to have your cancer under control. We call that your disease-free interval, where we've pushed you into remission and there's no cancer. So it's quite a complex balance, but very important question to ask, Mwenya. Thank you.
Thank you so much. And then throughout this discussion, we've talked about chemotherapy, we've talked about radiotherapy. Who then is responsible for administering this type of treatment to the patients?
Okay, so it's good you brought that up now, because we started off with the definition of the different specialists who work to treat cancer, and we've agreed that you need quite a number of them. So within the context of our setting in Zambia, we are proponents of a clinical oncologist, but obviously you may get a medical oncologist. So your breast patient will be treated by, in those centers where the two specialties are separated, by a medical oncologist who administers your systemic treatments. The radiation oncologist is the one then who gives your adjuvant or your added treatment to ensure local control using radiotherapy. And the radiation oncologist will also treat symptoms in very advanced disease like spinal cord compression, bone pains, that type of setting. But what I think is important, whether you have separated these two specialties or not, is the fact that you need to work as a team. So multidisciplinary teams are key. Tumor boards are important. So we have a multidisciplinary tumor board where a patient's case is presented and the best plan for treatment is arrived at from the team perspective. So at least I've seen an improvement where it's not, in silos, some ex-specialist gave this or did surgery. Before we actually do anything, we meet as teams of specialists and we discuss what is the best course of treatment for a patient. Yeah.
Okay, thank you so much. We are so much enlightened about that. Moving on to chemotherapy exclusively. What is it? What is chemotherapy? And if at all there are types of chemotherapy, what are the types of chemotherapy available? And which one would you advise one to go for?
Well, okay, that's a good question, Mwenya. And I'm just realizing, like, having this chat, gosh, it's such a complicated topic to try to simplify to understand, but I'll do my best. So we talked about the issue of use of systemic treatments and chemotherapy specifically. So these are those drugs that literally kill cancer cells, and they kill these cancer cells using different ways. So your mechanisms are different. So when we start talking about the classes of the drugs used, I'll say this is chemotherapy. Oh yeah, but you can classify them. This drug works in this way. This drug is specific to the cell cycle. This drug will go and disrupt your DNA and it works at a nuclear level. This drug does not respect the stage in the cell cycle, because remember, we defined cancer as abnormal cell growth. So if you remember from, is it 5th or 4th year when you do your cell division, you understand all those phases of the cell cycle. There's the other issue of what makes a cell grow and then stop. I eventually go into die, your apoptosis. Like the way our body is programmed is that we renew certain cells in our body, right? So certain cells will grow and they'll eventually go into this stream of, okay, now the body has gotten rid of them because I've got new cells. So these drugs, I'll give you an example. And if there's a breast cancer survivor listening in, here's what they call your adriamycin or your doxorubicin. Now, doxorubicin belongs to a class of chemotherapy drugs we call cytotoxic antibiotics, right? So they are specifically working at the cellular level in the nucleus and killing the DNA. Any cancer survivor is going to tell you that's the red devil. And it's the backbone of treatment in breast cancer specifically. So adriamycin becomes one such example. Other drugs might be anti-metabolites like your 5-FU, 5-fluorouracil, which is used in combination. Now, all these different classes of drugs from over half a century ago, when your scientists began to understand how they work, to reduce on their, I'll use a term I haven't used yet, toxicity, so their complications, you have to combine different classes of drugs so that you get a very good effect. So you cannot pick one drug and say, I'm going to use this, it's preferred over this. But generally, it will be a combination of either 2 or 3 different drugs. And then to make the story even a little bit more interesting or more complicated, is you begin to go now from your, we're talking about combinations. Now we begin to talk about lines of treatment. So the very first time you are encountering your doctor, we call that first line treatment. If at some point your cancer comes back, or within the context of treatment, your cancer is not, reducing, we have to change the drugs. We call that second line. Then we go on to the third line. Then we go on to the fourth line. And we continue giving this chemotherapy for as long as it is working. So that's specific to chemotherapy. And you've brought out a very important component. I don't know whether we have time to discuss, but for now I'll stop here and listen to what other questions that are there. Yeah.
Thank you so much. We've heard about personalized treatment with regards to the treatment of breast cancer. What exactly is personalized treatment?
Interesting question, very important, because we talk about evidence-based practice. By evidence-based practice, you are basing your recommendation of treatment on certain results. So research has been done. People with this stage disease have been treated, and okay, your overall survival is 50% or 60% at 5 years if you use this combination of drugs. These types of treatments, like I was pointing out to your first, second, and third line within our context, are not in essence personalized, because to personalize a treatment, you have to understand the individual's disease. So we're talking about breast cancer. It now brings you to understanding the types of breast cancer. They are mainly 4 types, and they are different in the way they behave. So when you make a diagnosis, we'll say, okay, you've got hormone-sensitive breast cancer, low, I don't want to use the Ki-67. I'm trying to think how to simplify that. So the cells are not dividing rapidly. So it's a low grade, right? Hormone sensitive, low grade. Okay, we can give you hormone therapy, because if I give you chemotherapy, it's not going to work well because your cancer cells don't divide rapidly. What about those who have a high Ki-67 showing that the cancer cells are dividing rapidly? Okay, we're going to give you the chemo, then we'll consider your hormone treatment later. Then you get a group with what we call triple negative breast cancer. So your receptors, you look at the estrogen, progesterone or progestin, and you look at the epidermal growth factor receptor. These are all negative. Okay, so they have what I'm calling TNBC. Different drugs are going to work. So in a sense, I'm now considering the type of cancer somebody has, understanding it so that I can personalize the treatment to them. Further, in very early stage of breast cancer, we want to understand certain genetic makeup. Apart from your BRCA1, the BRCA genes we talked about, there's a whole new set of genes that can help you understand how somebody's cancer is going to behave if it's in its early stage, so that it guides how you treat it. Can you avoid chemotherapy altogether? Should you just give hormonal therapy? At what point are you going to use those targeted therapies we talked about? So I hope that by unpacking it into this sort of long-winded explanation, there's an understanding of, what this is when we say personalized treatments. Unfortunately, it's something, like I say, within the context of low resource settings that is not yet tenable, but we do at least try to understand the basic 4 classes. We may not be able to do the genetic profiling to understand the exact behavior of this cancer so that we tailor your treatment appropriately. Yeah.
All right. Yes, and through that explanation, I think you've tackled a question from the comment section, which was about hormonal therapy. Well, there was a question stating if at all there is hormonal therapy for breast cancer. I think you've tackled that in your explanation.
Yeah. And different drugs within the class of hormonal therapies as well. Yes, there is. Yeah.
Mm-hmm. Okay, so now we'll move on to radiotherapy. We're talking about chemotherapy. Radiotherapy. How is it administered to the patient? And why should a patient receive radiotherapy? And then are there instances where you say they will only receive chemotherapy and not radiotherapy, or radiotherapy and not chemotherapy, or you administer both of them to the patient? I would love to find out.
Yeah, okay, so I'll try and because we sort of talked about it when I mentioned the fact that you have to use different ways to treat so that you reduce the risk of what local recurrence. So radiotherapy, we call these indications. In what circumstances are you going to use radiotherapy? So certain stages of the disease. So your advanced stage, definitely. If someone has had breast conserving treatment, definitely they'll need radiotherapy because there's evidence to show that it helps reduce the local control of the disease. It's in the early stage where things begin to be a little bit tricky because a surgeon may have taken everything out. We call those margins. So I look at whether there were any microscopic cancer cells that remained and other factors. Young age, aggressive disease, lymphovascular invasion. So we call these now your risk factors that indicate whether a client is going to have a higher risk for recurrence, and therefore we should use radiotherapy. Traditionally, it's used in the adjuvant setting, but you may use it in the setting of palliation as well. When someone has got huge disease, it's fungetting, and even within the area of radiotherapy, the techniques are improving, the machines being used are improving. So if anyone has seen, there's a couch, a patient lies on the couch, you position them, there's a head over them where x-rays come from, and we position them, take x-rays, we plan, and they lie on the machine, and the machine is on. They don't actually feel that they're getting the radiation, like I said. So these are x-rays penetrating the body or the area that you want to treat. So should you choose one over the other? Not really, because you have to consider the setting of treating. Is it adjuvant? Does an individual need chemotherapy? Can you do without chemotherapy based on those other issues I've discussed? And yeah, so at some point, like they'll say about 60% of all your cancer patients, breast included, breast cancer patients will need radiotherapy at some point in their disease course. Yeah, so it's a very important component of managing breast cancer.
All right, thank you so much. Well, we've had an elaborate discussion about treatment, chemotherapy, all these sophisticated terms. So then I'm sure, like me, everybody else is wondering who then bears the cost. You have a patient with breast cancer, chemotherapy is there, radiotherapy is there, but then who is going to bear the cost of these treatments? Thank you so much. Could you please address it?
Okay, so short, I actually, interestingly, we were discussing our National Cancer Control Strategic Plan. So obviously different countries will have different health financing systems, from out-of-pocket, patient bears cost. I know I've communicated with colleagues from Kenya, Nigeria, Ghana, and you find that in some countries, treatment is at cost to the patient, which makes access, next to impossible. We are lucky because treatment is really paid for by government. Yeah, so but paid for by government. How the patient comes and we do the treatments, the drugs are bought by government and everything else. But the fact that we now have a new concept of national health insurance that then will develop into obviously a mixed type of health financing, so that, but you've heard, especially on social media, patients complaining, you know, I have to get my money and I have to pay for this, I have to pay for that. So within the context of cost, it's quite huge, the cost to treat breast cancer. The chemo agents are pretty expensive. When you start going to your targeted therapies, it's, you know, the pricing is mind-boggling, to say the least. You can have a drug that costs the value of a small 2-bedroom house in Challenge for one cycle. So you begin to see, I'm actually very curious about issues of health financing. How is it we can make these treatments affordable? Obviously, one of them is through your national health insurance schemes, but I think we need to be a little bit more innovative if we are going to really give access to, and the key here is good quality treatments, because in all the years I've been practicing, I always feel like, okay, so if you're low resourced, it means that you get your, you know, your second tier type of treatment and not the first. But yeah, hopefully, Mwenya, people like you are going to be health economists or something, and you know, figure out financing, because even for radiotherapy itself, your machines are exorbitant in pricing, but for Zambia right now, the government bears the cost. We have NEMA, your National Health Insurance Scheme, which is coming on board to help, but that does not close other ideas on how we can make these treatments accessible to everybody and of good quality and at reasonable cost.
Thank you so much. Indeed, I'll convince a few of my colleagues to come with me on this journey as we make medical treatment free for all, especially with regards to breast cancer. Well, we'll move on to the next item in our discussion. There are patients who present not only with breast cancer, but then they may have other diseases, other comorbidities presenting with breast cancer. So is there a way or an interaction between the two treatments? You have a patient taking a different medication, then they are on chemotherapy or radiotherapy. Is there a way that these two interact or downsizes or downplays the other treatment? What is the effect?
Okay, yeah, that's a very important question, because as we discussed, you know, you always now begin to think of drug-drug interactions. Is maybe one drug going to be potentiated? It becomes more toxic. Should you reduce the dose? Should you not? So that's why it's very important to work as teams. So let me give an example of HIV. If someone is on antiretroviral therapy, we do not stop that treatment at all. And over the years, we really haven't seen any type of, you know, interactions when they are getting the chemotherapy. For us to say, okay, can I reduce the dose of the chemo or can I reduce the dose of the ART? That has not happened. So you usually, again, look at your patient as an individual. You look at the disease they have, whether it's under control or not. It's more like what might make treatments difficult might just be the fact that your disease, whatever comorbid condition, is not properly controlled. So when you think of hypertensive heart disease, for instance, in that one, we will not give your adriamycin, your doxorubicin, the red devil. Why? Because it is cardiotoxic. It has harmful effects on the heart. So you have to measure the balance again of benefit risk, and you have to do certain tests to ensure that you are following. Because if you just went in and gave everybody, let's say, your doxorubicin, you might end up with a lot of cardiomyopathies, heart failure, and you get your physicians to now be burdened with a lot of conditions that they have to manage. So key here is, yes, we do look at the comorbidities, we look at the treatments, we look at whether this comorbidity is controlled or not. And in an instant where we feel like there is some complication, we may have to omit certain medicines, but remember the combinations are several within the realm of the chemotherapy agents that you use to treat breast cancer. And we have to weigh the benefit versus the risk.
Okay, thank you so much. From the comment section, there's a question which would love you to address if there is a relationship between polycystic ovarian syndrome and breast cancer.
Okay, so it not directly, but what you may there's what we call the breast ovarian syndrome, right? So you may get a patient who has a predisposition to breast cancer because of this breast ovarian syndrome. So it could not, but we've had patients who had ovarian cancer who later on developed breast cancer, or vice versa, where someone has had breast cancer and they went on to develop ovarian cancer. The percentages luckily are quite low because most of the breast cancers that we see are what we term sporadic. So this term is so annoying because everybody wants to know what has caused it. But I'm saying, oh, well, 90% of breast cancers are sporadic, meaning all those things we talked about might have played a role in this disease developing, but there might be a small percentage of patients who might be more predisposed because they've got this breast ovarian syndrome, and they can't develop pure ovarian cancer or they can't develop breast cancer. And it's really now at a genetic or hereditary level. I hope that answers that question.
Yes, it does. Thank you so much. Right there on this discussion about treatment, what are there any adverse side effects of this type of treatment? Do you have patients that have halted treatment because of the side effects? What should patients know, or what should they anticipate as they take this treatment?
Okay,
thank you.
So we have to sort of break the treatments as we've discussed them. The main one, let's talk about chemotherapy or systemic treatment. So obviously chemotherapy has side effects, and these may be early on, during the 3 months or just in the course of treatment. So we call those acute side effects, or late side effects, which develop way after an individual completed their treatment. So what are the common ones? Nausea, vomiting, suppression of the bone marrow, so anemia, HB is low, white cells are low. If white cells are low, they are our defense against infections. It means that someone can actually get your infections. So neutropenia is low white cells. Neutropenic sepsis is low white cells coupled with infections. And then these infections can be anywhere. It can be pneumonia, UTI. It might actually go into your septicemia. So these are very serious side effects. The other ones are not so bad, but obviously they affect an individual's perception of who they are in terms of beauty. So they lose their hair, they get darkened skin, including the nail beds, the hands. I've had patients who've told me like, oh, someone asked me to wash my hands, like, were you touching charcoal or something like that? So other serious effects, and obviously I'm sort of lumping them, but for specific types of chemo agents or chemo drugs, you have different sets of side effects. So I'm sort of just lumping everything together. The other one would be what we call the hand-foot syndrome, where somebody develops this dermatitis as a result of some chemo drug that we've given them. Neuropathies, your numbness, the burning sensation in the feet, the hands, the loss of grip. Someone just now has butterfingers and they're dropping everything. So those are some. Oral sores. That's also very common, especially for your 5FU type of treatment. So they can get mucositis, as we term it in medical terms, but these are just sores in the mouth that may lead to a reduction in someone's intake, and they, your weight loss during treatment is quite common. So depending on the severity, it can be mild, moderate, or severe. We've had certain clients who really have sort of, I'm not going to go through with this treatment because I cannot deal with the side effects. But remember, as a team treating a cancer patient, we explain the side effects and we manage the side effects. So we do encourage our clients to be on the lookout. We check their bloods regularly. We give them supporting treatments to ensure that they can really go through this treatment, which is really very, very important. Now, when it comes to radiotherapy itself, the side effects are not as severe as the ones for the chemo, but mainly, remember, in breast cancer, when we treat with radiotherapy, we are treating the chest wall, or we are treating the area where the breast was. So you get a bit of darkening of the skin in that area. It can start to dry and peel. We call that dermatitis. You may, especially depending on treating your armpits, if the surgeon did not take out the lymph nodes, sometimes we have to extend our treatments to include the lymph nodes in the armpit. We may then give a dose of radiation which is slightly higher than what the brachial plexus should be able to tolerate, and someone might develop what we call brachial plexopathy. The other side effects, and brachial plexopathy would be your weakness in the hand. They may have the same neuropathies we talked about. The swelling of the hand is quite common. Now, swelling of the hand is more a surgical side effect. Remember, the surgeon is going in, and that is why practice is changing. And I do hope Miriam will talk about this. What are we doing to try to reduce the incidence or the rates of lymphedema? We call that lymphedema. It can be quite debilitating, especially if it's severe in patients with poor circulation. It can lead to sores. Yeah, so those are just like some. We need to think about them from the perspective of the particular treatment you are giving, then think of them in the immediate short time or later on. So later on, if someone had radiotherapy, the skin thins out, we call that skin atrophy. The effect on the heart, your cardiomyopathies can develop. Someone can have your heart failure, but this again is what is sort of, your rare percentage. But regardless, when we are educating our patients, getting the consent for treatment, we are obligated to explain about these side effects so that they are informed and they do get the treatment from the informed perspective. Yeah.
Yes, thank you so much. One thing I've noted from your explanation is that really the benefits of the treatment outweigh the risks. So we are all encouraged, if at all there's somebody with breast cancer here, or we know of somebody with breast cancer, we should encourage them to go for such treatment. Thank you so much. Well, moving on to our next item. How soon after diagnosis of breast cancer should one commence treatment? Should they wait for a while at home, or do they begin immediately after the diagnosis? Thank you.
Okay, immediately after the diagnosis would be lovely, but we talked about counseling. This is a devastating diagnosis, so we do give time for a client to process, but within the shortest possible time. So when you look at recommendations internationally, you must really start your treatment within 2 weeks of a diagnosis confirmed. What sort of makes the treatment from diagnosis to start of treatment in our setting long is the protracted time it takes to get a diagnosis. So I'll in this instance just say in the shortest possible time, because I'm very cognizant of the fact that we may need to do a lot of counseling. Remember, I can't give a treatment that a patient has not consented to. So we need also as clinicians, as practitioners, to take this practice of taking informed consent very seriously and referring our clients to other specialties for social counseling, for instance, if you've got your palliative care team, you must also help them by introducing them to a survivor so that they see someone who went through the journey and is doing okay. So that also encourages them. So in the shortest possible time, where possible, please, 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 to our clients, anyone diagnosed with breast cancer, do not go away home and stay away for months on end, because the cancer does continue to grow if it is not attended to. Yeah.
All right, thank you. So we have noted that you've been working at CDH since 2007. So from your experience, what is the prognosis of breast cancer? As in, what is the outcome of breast cancer for the patients that you have administered treatment to? Thank you.
Okay, I think this is where the scholars of POHER come in. We need to sort of go back and get our evidence out there. So we've got quite a lot of data. We're currently working on trying to figure out that answer to that question. But we do know that survival is poor, right?
Yes.
I'm sure at 5 years, it's somewhere around your, depending on the stage, probably for early stage, and by early stage, probably I'm referring to your stage 1 and 2, and I'm now using anecdotal type of, and basing my my estimation on just what's pertaining in the literature, is that the percentages at 5 years would vary from as poor as 35 to maybe something like 60%, and I might be pushing the 60% a little bit on the higher side. We do have a lot of data. We have a database at the hospital where we've entered all these, and we keep entering the information. So we'll have more exact figures very, very soon, hopefully by December. But from the general perspective, your survival percentages even fall further the higher the stage. You know, stage 3, you are probably in your 40s as an average at 5 years. And maybe just to explain to the to the people who are signed in, when we talk about outcomes, right? What do we mean? Our aim of treating non-metastatic breast cancer. So our aim of treating a disease that has not spread outside of its origin is really to effect a cure. I might sound like I'm contradicting myself, but that is our aim. So when we, let's say, treat 100 people with the same disease, same condition, then we follow them and see whether, one, the cancer has come back locally, or maybe the cancer has come back at a distant site, as we discussed, your lung, liver, and other areas, or sometimes the cancer comes back local and at a distant site. We are now talking about recurrences or your disease-free interval. How long is this individual living without the cancer? How long are they surviving with or without the cancer? That is your overall survival rates that we talk about. Sometimes, even when you read the literature, you may come across things like breast-specific survival. So I want to know, apart from other causes of death, which could be diabetes, you know, COVID now has really led to quite a number of mortalities, but you want to know what percentage of your patients actually die from breast cancer. So summarized, the figures in low resource settings aren't too great. The figures in Zambia are no better, but our aim in having such discussions is really to upstage so that we stop seeing your stage 2s and 3s and we start seeing your stage 1s with effective systemic treatment. And I must emphasize, with effective treatments, surgery, your chemos and everything else, we should begin to see better results. But you can't start seeing these. It might take a decade, another 20 years before we can actually get these figures to go up. Yeah.
All right, thank you so much. Well, we have a couple of questions from our question and answer. One would love to find out if contraceptives have a bearing on breast cancer. Do they predispose one to developing breast cancer?
Okay, very controversial. I know in our questionnaire, we do ask whether there's been use of oral contraceptives, but it is not in terms of if you used or did not use, are the ones using going to be more predisposed? But it could also be when we talked about the risk factors. Remember, I talked about the exposure, this prolonged exposure to estrogens that predisposes. So some literature will say yes, other literature will say no, right? But again, it's yeah, I do know the issue of family planning is very important. And again, it's not the one singular reason why somebody would go on to develop breast cancer. Yeah.
All right, thank you so much. Well, there's another one asking about benign conditions of the breast. For instance, fibroadenoma of the breast. Will it then predispose one to getting breast cancer? Will that transform into breast cancer? Thank you.
So within the So within the context of risk factors, we do appreciate the fact that fibrocystic breast disease is a risk factor for breast cancer. So fibroadenomas, they may be removed, but an individual with such a history may be at a higher risk of developing breast cancer than somebody who does not have these benign breast conditions. So I do hope that then answers the question. Yeah.
Yes, thank you so much. And then one other one concerning investigations, i.e. ultrasound and mammography. When do you use an ultrasound and when do you use a mammogram? Thank you.
Okay. All right. So medical students will remember when I say triple breast assessment, and they very quickly tell you clinical breast exam, ultrasound, and a biopsy, right? So within the context of mammography, in our setting, we are using it more as a diagnostic tool. So if someone has breast cancer on one side, left or right, I need to know what the condition of the breast is on the other side. So in that instant, I'm going to use your mammography as a diagnostic tool. Mammography can be used as a screening tool, as we earlier discussed, right? For those women of the age, like in Zambia, we say 40 and above. Elsewhere, they'll say 50 and above. So mammography can be used as a tool for screening for breast cancer. Have I left out anything, Mwenya? What else was in the question?
No, I think you've addressed the question in its entirety. Thank you so much.
Okay. All right.
Yes. I would love to find out if there has been any research concerning breast cancer treatment or diagnosis. Has there been any improvement, if at all there has been research done? And then how do we compare the current trends in Africa to those of the Western world? Thank you so much.
Very interesting question and challenging in terms of answering. So currently there are, I know there are consortia, especially ones looking at the genetics of breast cancer. I can't remember, but I can look it up and later share. There's a consortium that is looking at the genetics to understand why Africans and African Americans and other minority races tend to have aggressive disease and advanced disease and shortened lives of breast cancer. So that is ongoing. I'm going to really share, because I did attend a conference recently. I can't remember what that consortium is. So that's from the context of what is going on the continent. Research from the perspective of systemic treatments it's ongoing. There's several of these going on, and you can't even keep up with the rate at which recommendations are made to use the different drugs. So there's very different types of research that go on to try to see which is a more effective agent, when can you use it. So that is evolving. And for the sake of students, if you go to Google and you type in up to date, you do find this site where it summarizes all the different research that is going on in different areas, including the area of radiotherapy. In radiotherapy, research would be more about the techniques, for instance, of treatment, because we can't reinvent the wheel. If research was done about the fact that giving radiotherapy after a breast conserving procedure does prolong life or improve overall survival and lead to better local control, it's a fact, right? That's evidence that's there. However, within the context of radiotherapy, we need to know we have different techniques of treatment. There's technologies that are different. How do we minimize, let's say, dose to the lungs or dose to the heart? So there would be research in that context. So now when we talk about trends, I guess your question is more about, is it about the incidence of breast cancer? Because it's a proven fact that the incidence of breast cancer in low resource settings is actually going up, right? So Ugandan cancer registry data is a good example of that, where you begin to see that maybe in the 70s, the numbers compared to now when we are in this millennia, obviously more people are tending to get breast cancer. Globally, though, if you look at the breast cancer profile globally, we say it's the commonest cancer in women, right? Globally.
Yes.
I think it is soon overtaking lung cancer, because if you look at your first world, lung cancer used to be like the biggest problem because of issues of smoking and everything else. But in women, breast cancer was always like the number one. Now, when you come to areas like Zambia, the incidence, when you go into your statistics, doesn't seem to be as high. Then the question is, why are we bothering? It is the disproportionately high mortality rates. So your high mortality to incidence. So simplified, I would say in a low resource setting, 2/3 of all breast cancers will die. In a high resourced setting where they have a higher incidence of breast cancer, survival there is better. So their survival rates beat us by far. So we're talking about I was giving an estimate of, let's say, 60-50% at 5 years, if it's stage 1 or 2. In the West, that figure is going to be about 85-90%. So you begin to see the disparities. So when we talk about research, we have to really look at it from the continuum of care in terms of prevention, early diagnosis, treatment, and supportive care. So within the realm of screening, there was a study, Zambia was a site, it's called the ABCDO study, where they looked at disparities in outcomes of breast cancer treatment. I think there were a couple of other countries, Nigeria, Kenya, I can't remember the other one, but what they found in that study was that really this conversation we're having about the very poor survival rates, like at 2 years, you might even say like, okay, only 40% are alive at 2 years. Those are alarming statistics when we think of it. So in terms of research, what our own country does not have access to is research into newer drugs. So we talked about immune therapies, we talked about targeted therapies. All we are going to get are these results from the West, and then we have to adapt them to the local context. But remember, cost is very prohibitive. I did allude to the fact that some of these treatments, just one cycle of the treatment, can cost you the value of a 2-bedroomed house in Chilenge. And I kid you not, that's just a fact. So sometimes I might be philosophical here. The question as we begin to go into the next phase or the next decade or the next 2 decades of oncology, and specifically of looking at breast cancer in our context, would be how do we make these treatments accessible if we know they are life-saving. I know there's the issue of, okay, let's harmonize or standardize the treatments, let's divide them according to resource settings, but there's the component in your heart like, okay, yeah, resource stratified, well and good, but if the best treatment is X, why am I getting Z? You know, so yeah, it's sort of challenging, and I don't have the answers to that. But as an advocate, I try to think, how can I have my clients have access to these very top? But I guess the answer would be through research. So with POHER and what you're doing, and you as scholars, I do hope that some of you do take on breast cancer as a cancer that requires a lot of study. We need to understand it within our local context and the systems that work around it. Yeah.
Okay, thank you so much. Indeed, we're encouraged to take up research work to do with breast cancer. We're coming almost to the end of our discussion, but before we do, I would like you to address just 2 myths from my community about breast cancer. One,
Okay.
yes. One says, can breast cancer be caused by wearing a bra, or rather, can wearing a bra cause breast cancer?
And that's actually something that's so commonly asked, and we always say, no, it cannot. It's not something that is evidenced, but what people tend to think about, I guess, is, well, I think we had the previous discussion we had when we were a multidisciplinary team. I remember Miriam tackling this question and says, you know what, if you're going to wear something that's tight, squeezing your breasts, it's very uncomfortable, it's painful, it is not going to lead to breast cancer. It is going to make you very uncomfortable. So can we wear proper fitted bras for the right size of the breast that we have? Then we're not going to have that issue at all. So please, ladies, go out there, have your, the same way we know I wear size 6 for shoes is the same way we need to know, okay, I'm a cup A or B, my chest circumference is 36 or 48. So we need to really just change the practice and stop wearing these. I don't know if it's fashion. Maybe your generation can help me, to perk my breasts up so that I'm looking all glammy and beautiful, but at the same time, it's so uncomfortable. Yeah, so no, it does not.
All right, thank you so much. One last one. Is breast cancer contagious? I got that from my community. Apparently, somebody thinks it's contagious. Wow. And I would love you to address it. Is breast cancer contagious?
Okay, no, the simple answer, no, breast cancer is not contagious. It's not.
Thank you so much. I think we've come to the end of our discussion. If there are any questions in the comment section, I'm sure Dr. Akwi can help me bring them on here. But once again, thank you so much, Dr. Mwaba, for sparing time to come and discuss this concern with us. I hope that we'll have more discussions of this sort in the near future. And again, thank you, POHER, for this opportunity. Over to you, Dr. Akwi.
Thank you. Yeah, there's a couple of questions, but I'm looking at the time. It's always interesting, and I say this usually at most of the end, we plan for an hour, and before you know it, it's like, it's 2 hours later, you're still on there. But, I think we'll save some of those questions for, for next time or for later. And, I echo the sentiments Mwenya mentioned in terms of, how grateful we are for your time. It's a Saturday. We just spent almost 2 hours on here, just, educating. Yeah, it's such a very important topic. And, people listening, just get to know your body, feel your breast, do your exam. Maybe it's, once a month, select your birthday as a day to do it, or select the first day of the month as a day to do it. And I echo the sentiments Dr. Mwaba mentioned. When you have a question, seek help from a healthcare professional. That's why we're here. I always tell a patient, when in doubt, just ask. I don't think we're going to shame you for asking, but it's important to ask and because my understanding is, if we catch it early, we can prevent sort of the harmful impact, from breast cancer. So, so it's important, just know your body, get help, ask questions. And that's why we're, healthcare professionals here. So once again, on behalf of POHER and a personal note, absolutely grateful. And thank you so much for your time, Dr. Mwaba. And Mwenya, once again, congratulations to anyone who did not hear this message in the beginning. We have to brag about Mwenya. She is, great. Yeah, she's a Millennium Fellow, which is a leadership program as part of the United Nations Impact. And she was selected amongst thousands and thousands of applicants. It's not like, 2 people applied. So this is a huge, huge deal. So we're super proud of Mwenya, and we're just looking forward to her impact. And I know from the beginning, Mwenya had expressed interest. I think it was in OBGYN. So if breast cancer sort of falls in your realm of interest, I also got a clue or a hint from Dr. Mwaba. Maybe it was only me picking it up, that there's opportunity
the
for
nuclear
research.
Science and technology and research.
Yes. So there's always that, opportunity. And, as people are watching, research is important because it answers the quote unquote unanswered questions. It answers those questions about risk factors. It answers a question about treatment. What's good for you may not necessarily be good for the next person. So these are, that's an important aspect of medicine. Informed consent is something that has come up as well, meaning we don't force patients for treatments. Treatment is individualized, but we need to provide answers, to questions that patients may ask. And I really appreciate the conversation about side effects. That's always an important aspect. The example you gave, which is very interesting in terms of the darkening of the hands, where, like you were with Malasha. Charcoal.
Charcoal. Yeah. Someone was asked to wash their hands when they were doing fingerprinting, like, go wash your hands. But side effect of chemo.
Yeah. And that's just, that's definitely very important, because we don't want our patients to panic, or even their family members to panic. But when you had that conversation early on, like, hey, listen, these are your options. There's the option of chemo, there's the option of radiotherapy, there's the option of do nothing. There's the option of palliative care. We never force, but we inform. And understanding those side effects, I definitely learned something from this conversation today as well. So thank you both, for your time. And to the audience listening, we have a few more sessions this month dedicated to breast cancer. We are hosting a session on patient advocacy in the middle of the month. And then we do have a session towards the end of the month with Dr. Mutebi, Miriam Mutebi again, will be coming on.
Brilliant,
Yeah, so she'll be coming on, and she'll be talking about the, surgical aspect. And I love that the point you brought up, because that's a really important question to answer, whether you need to have a prophylactic mastectomy, you need to get your breast removed if you have maybe a family history of breast cancer, or if you're genetically predisposed. I think the conversation today was not finished, but it's definitely a great start. It was packed with information, and we look forward to having you again, Dr. Mwaba. I'll be on WhatsApp.
My pleasure. No problem. Just call on me. And when I should sort of interact with me directly, it's always a pleasure. I just love to see your young future generations, as I call them, come up. You are developing the leadership potential. And I have hope that before I retire, we'll be on a different level altogether in medicine in Zambia. So congratulations, Mwenya. It's been my pleasure, Akwi. Don't hesitate when I have the time. Like I say, I am a self-proclaimed advocate. So I should be able to give of my time and share my experience and knowledge. So thank you, POHER, thank you, Mwenya, and thank you so much. I didn't see the time go by, so don't worry about I mean, we could have gone on till 4, but so thank you so much.
Thank you, thank you, thank you. Mwenya, you both are in Lusaka, so
Yeah.
I'll be checking in the background whether you met up or connected. And on that note, good morning, good afternoon, good evening to everyone who is watching. We hope this has been as informative for you as it was for us, and we look forward to seeing you again. On behalf of POHER, thank you and have a fantastic day. Signing off.
Thank you.